Okay, well, welcome back, everyone. Today we are doing another episode of Mid Chat Monday Healthcare Specialty Series, and we have Dr. Malik with us, who is going to help us explore how to become a breast radiologist. Now, this is a very specific field within radiology, and Dr. Malik has a lot of experience being on camera, doing interviews, and so she's going to be a wonderful guest today. So, Dr. Malik, welcome to the show.
Thank you for having me. I'm excited to tell you guys all about breast imaging radiology.
Okay, well, before we jump into that, tell us a little bit about yourself, where you're from, and why you decided to go into medicine in the first place.
Well, currently I'm a resident in our nation's capital. I'm a breast imaging radiologist at Washington Radiology in D.C., Maryland, and Virginia. I hail from a small town in Tennessee. You wouldn't know from my lack of accent, but you would from my love of biscuits and gravy. So my parents are actually both foreign medical grads, and that's how we ended up in a small town in Tennessee. So I've always been exposed to medicine from a very young age. And then I was of the 80s babies, save the planet, save the whales, public health background, Outbreak, the Ebola movie with Dustin Hoffman was my favorite movie growing up. I thought I was going to be in, work for the CDC and, do that kind of thing. So I always had these aspirations of being in medicine or being in public health. So that's sort of what drove me towards being pre-med when I was in college.
And I'm assuming your parents played a major role because they were both doctors.
Absolutely. And because all the nurses and the MAs and everyone in the hospital and the clinics were my babysitters. So I've been exposed to medicine absolutely from a very young age, both the good and the bad of it. So, the hours were is something that I was exposed to, but also just obviously the ability to help people, had always been central to my life.
Now, did you know what you wanted to specialize in when you went to medical school? Did you have a very clear idea? Because I would assume that most people don't think they're going to go into breast radiology. It's something they discover with time. And,
right.
We're going to discuss that, in this interview.
Absolutely. I think that unless there had been some very young exposure, it was not on my radar at all. And in fact, I made several insulting remarks towards radiology, ones that I now try to correct people and make them more aware that it's not the dark dungeon that even I referred to it as. So no, I went into medical school. I had various ideas of what I might want to be. Of course, there was the Dustin Hoffman CDC thing that I might have gone for, but I also was interested in gastroenterology. I think as someone who grew up in America with a lot of sports, I had some small notion of being in sports medicine, and explored different routes and then came upon breast imaging radiology.
So why radiology? I mean, did you discover that in your third year, your fourth year of medical school? Were you exposed to it in the classroom? Where did that inspiration come from?
So the inspiration did come from third year. I went into my third year planning on doing internal medicine and then gastroenterology. And so on my internal medicine rotation, I wanted to be the best internist I could be, which meant reading all the EKG books, the Dubins and those, and really learning those cover to cover. And then someone told me to read Felson's chest radiograph primer cover to cover, and so I did. And in the process, I thought, wow, this is actually a lot more interesting than what I had given radiology credit for. We had probably two areas of exposure in anatomy. We would look at, chest radiographs or CTs, and we'd have to identify the body parts on the CTs. And then, of course, with neuro, that helped with a lot of the anatomy. And then just learning the densities of things on X-ray or CT. And I didn't find that particularly exciting, but when I started reading this whole book and the things that you can actually diagnose on a chest radiograph, I mean, you can diagnose all sorts of chronic processes, all sorts of systemic processes, not just, there's a consolidation, there's an opacity. And I found that really, really interesting and exciting that there was so much that you could learn about a person just from a single or two images. And so that's where that came about. And coupled with, I realized I didn't like internal medicine as much as I had hoped to. And I think it's great for so many people. I mean, my sister's an internal medicine gastroenterologist, but I realized it wasn't for me. And at that same time, sort of parallel was this separate I started realizing that I liked radiology.
How did you know it wasn't for you? Because you had this clear idea you were going to do gastroenterology, and then here comes this textbook, and all of a sudden, your life plan really kind of changes, right?
It did. And so I was at Tulane for medical school, and it was post Katrina. So Katrina hit at the beginning of, Hurricane Katrina hit at the beginning of my second year of medical school. And so third year we were going back to, really substandard healthcare in New Orleans. These, people had been neglected for, months, years, in addition to the already chronic processes. And I just realized that, as we all know, medicine isn't always the sexy Grey's Anatomy. It's not always treating these acute problems. It's not always House MD where you're figuring out this really interesting zebra. It's a lot of chronic processes, chronic illnesses, and unfortunately, oftentimes non-compliant patients. And for me, that just didn't I didn't get all buzzy about that the way that I could about a chest radiograph. The way that I could and I realized that I was very cerebral in my thinking, and I really liked to figure out problems and to figure out what was going on and how to fix it. I realized that I was goal oriented, and a lot of these things happen over the course of time. You don't know those things when you're going to college. You don't know those things when you start medical school. And so I think really over the course of time, learning those things about myself is what helped me realize that radiology would be a good fit.
So moving forward, I'm assuming you did some rotations in radiology. In your third or fourth year, or was that more closer to your fourth year?
I did both, actually. So right after medicine, when I realized that I didn't want to do medicine and maybe radiology was becoming more interesting, I actually had the good fortune of working with a breast surgeon while on my surgery rotation. And he was one of the old school kind that did a lot of biopsies in the office and did a lot of work with the patients. And so I realized that I was much better at procedures than I ever could have imagined. I previously thought that working with my hands isn't something that I would enjoy. I didn't plan on liking surgery. I didn't plan on liking, to do procedures. And so that was something I think that was also really important in pushing me towards breast radiology. And he inspired me to work with a breast radiologist. And then separately at Tulane, we actually do have a 2-week requirement for radiology because they understand that it is central to so much of what we do in medicine, certainly in today's.
It seems like you really need a great mentor when you're in medical school. Even though your parents are doctors, my father's a doctor, it seems like you still need to find that mentor because that mentor can inspire you in different ways that you didn't think were possible.
Absolutely. Absolutely. I definitely think for me, Dr. Steve Jones at Tulane and LSU was the one who recognized my own potential that I had either buried or just hadn't realized I hadn't unlocked it yet. So absolutely someone that, sort of pushes you and sort of encourages you to go outside the box a little bit, and outside your own comfort zone, because that's the only chance you're going to get to really discover the different options that are out there.
Do you think the medical schools can do anything different to inspire medical students in their first or second year about considering radiology? Because you're right, they kind of glance over radiology in those first 2 years of didactic, classroom interaction.
Absolutely. I mean, I think, listen, if I hadn't already wanted to go into radiology, sitting behind someone in a dark reading room is not the way that would have inspired me to do so. And I see so many medical students who come in preconceived notions and don't leave with anything different because it's not interesting to sit behind someone and do nothing. And in many the way that at Tulane we had suture clinics and we would go in the ER or we'd go learn how to read EKGs. I mean, it's really hands-on. It inspires anyone to want to do anything. And so I think if there were kind of chest x-ray primers, just like what I had, or, better correlating the gross anatomy with CTs. I mean, we did have a couple of images, but making it a little bit more interactive. I think schools are starting to do away with the actual gross labs. So maybe that's one way for radiology to really enter that sphere a little bit more. Because
you're right. I think definitely during the the anatomy lab your first year, they should definitely integrate more radiology into the classroom because it'll bring the experience to life a little more in terms of what fields you can pursue.
Absolutely. And I just think that, I mean, for so many people, even outside of radiology, they're making it more a part of their own practice. We see surgeons are looking at images every day. A lot of my medical subspecialties are looking at them every day. Obviously, emergency medicine, sometimes they're now even doing their own ultrasounds. And so it's so important for what we do in medicine today. It really advances and has advanced diagnosis. It's advanced, treatment techniques. So I think that it needs to be a bigger part of the medical education.
Okay, so fast forward towards the end of your third year of medical school. I know we're going back a few years.
Sure. Hey, not that many.
You're saying to yourself, okay, I'm going for radiology. Did you start applying for rotations for your fourth year so that you could be prepared for interviews? I mean, what advice would you give to a medical student who is thinking about radiology as a potential field to pursue?
I did. So I did, because of the surgeon who I worked with pointing me towards a breast imaging radiologist. I sort of had a local mentor, as it were. And then I did speak to other fourth years, getting their experience from the interview trail and things that they had found helpful, which is, obviously going to someone who's just been through it, because as we all know, the match changes from year to year. What's more or less competitive can change from year to year, and what programs are, the ones to go for changes from year to year. So I really found that I got a lot of pearls from the people who were going through it or had just gone through it. And
so definitely, one thing you advise is speak to your peers, speak to upperclassmen, just see where they've rotated, and just get a general sense of and feel for what the environment's like.
Absolutely, yes, and that's what helped me. Actually, I ended up doing a month of research at NYU, which probably still is, and definitely at that time was one of the more competitive residency programs to get into. So we all know, even if you don't think you're going to go to NYU, or even if you don't think that you're going to go to one of the more competitive programs, always good to be getting, connections, letters, experience, and making connections that way. And so I did that. So I did some research there, and I did throw my net, as it were. I cast my net wide, and I did a rotation in DC. I did a rotation in Chicago. And so I felt like I had 3 major cities covered, right? And that's one of the ways to, with like 7 or 8
to lower stress levels a little bit.
Right. You have so many programs in Chicago, you have so many in New York, and so you sort of cover a few bases that way. But also they were cities that I was interested in moving to. I wasn't, going. Mayo Clinic is a great place,
But it wasn't for you.
Right. I knew I was never going to go to Rochester, Minnesota. So I didn't even think it would be worth it to get the experience from there. So I think we each make our own decisions on how much location and program and things like that.
How important is research in terms of preparing your application?
So research, I think, is important, not just for radiology or not just for an application, but I think just for medicine in general, really understanding evidence-based guidelines, right? Understanding how to dissect a paper, understanding materials and methods, just when you're moving forward in practice. For example, the American College of Physicians just came out with their guidelines for screening mammograms, and I'm able to respond immediately, whether it's on social media or if a patient asks me or a referring provider, because I can dissect what papers they were using, what evidence they were using. So research is important, just period, right? It's what moves medicine forward. But also, it obviously, if you're doing meaningful research, can move you forward, even if it's not related to radiology. They just want to see that you have an interest in academics, an interest in clinical medicine, an interest in moving, any field related to medicine forward. So obviously, if you make advancements in your own field, that's going to end up, giving the gold star. But in the end, I think they just want to see that you have an interest.
So let's move forward. You get into residency. Do you recommend to the applicant to pick the place that is the most competitive? Are there certain environments you should be applying for? Are there certain programs that are stronger for different areas of radiology?
So for me personally, but I also think it's a good recommendation. You want to be going to a big program for a couple of reasons. One, the more people, the more chances for learning, both from your peers and from other attendings. But also, if you're at a small program, you're going to be covering calls every other day or every 3 days or every 4 days, right? And while taking call is very important to what we do, we obviously all learn on the job. It does detract from the actual academic experience of residency. So I was in a program that had 13 residents per year that allowed, I was still on call what felt like all the time, but, we were able to.
Don't we all feel that when we're residents?
Yeah, exactly. So,
but 13 you're saying is a lot for a program. That's a big number.
13.
And that like lowered the burden of having so many call days.
Right, because I saw several programs that were 4 residents per year or 5 residents per year. Now, they're also going to be at hospitals that don't have nearly the number of level 1 traumas, say, for example, that Parkland had. But, and you want to be looking for, yes, things like level 1 trauma center. If you're not at a level 1 trauma center, you're not going to get all those gunshot wounds and all those things that you might have to go out and read in the workforce. So I do think being at a program that's big, being at a program that's at a level 1 trauma center. So you're expected to be setting up, angios. You're expected to be reading all these like high flown cases that you want to get under your belt before you go into private practice or academics, whatever it may be. And I do think you want to be looking at a program that has a wide variety of fellowships for 2 reasons. One, of course, if you were able to match in-house, that would be great. And 2, is it just
does that happen, if I may ask, does that happen commonly where if you're in the residency program, they tend to take residents from that particular program into their fellowship?
It's my understanding that all radiology fellowships are now match. When I was back in my day, they weren't all match. So you could, sort of get into a spot without a formal process. I believe they might all require match now. So unfortunately that is not, it's not as easy as it used to be, but I still think you form connections with people within your own specialty. They can help you, move forward, but also it just means that it's a bigger academic environment. And, again, that's what residency is about, is the experience, the training, the academics. So. Okay.
And could you tell us a little bit about I'm assuming it's 4 years or is it a 5-year program?
So there are a couple different options. So radiology itself is the 1+4. So intern year plus 4 years of radiology and then plus whatever fellowship you go on to do.
So it's really 5 years. And then if you're considering a fellowship, it's longer.
Correct. I was actually in a combo program at the University of Texas Southwestern, which is no longer offered. It was actually a combo 5-year. So PGY1, day 1, I was a radiology resident. Now we did a lot of clinicals and we did directed clinicals that were meaningful to help complement our radiology experience. So a lot of ER, a lot of ortho, a lot of urology, things that we were seeing a lot of on call. There are still some of those programs. They're called categorical programs versus diagnostic programs. There's also the new IRD or direct to IR programs. And there's some, I think, also IRDR programs, IR being interventional radiology. So I can't speak as thoroughly on those, but they do offer a more direct route to securing a future in interventional radiology while still offering some diagnostic background, which is obviously.
And how are the hours? How intensive is the residency? I know you mentioned that there are many call days that you have to meet, but in terms of the intensity of the program, the academics, what does that kind of look like for those first 4 to 5 years?
So, for most programs, for many programs, it's a lot of academics when it comes to radiology, and we have to learn, in theory, everything about everything in the body. And so in my program, we had a 7:30 lecture and a noon lecture every day. And
that was for 5 years or 4 years?
I was there for 5 years. So, and that was, you would have some services that started before that. All your interventional services started before that. So you might get to the hospital at 5:30 or 6 o'clock to start working up your patients, but at 7:30 you were expected to be at lecture, and then services started at 8:30. So obviously there are radiographs and CTs being done during that time. Call residents were, usually there till 7 or 8. And then the difference between what I feel is the difference between other specialties in radiology is that the radiology attendings are still doing a lot of work. It's really not even possible, I don't think, for the residents to do all of the work that happens in a hospital during a day. So the difference is that they understand that while we are meant to be workhorses also, and we certainly are relied on at night, during the day, there has to be some room for learning. The board structures have changed since I've been there. My class was actually the last class to take the oral boards, which were a rite of passage in radiology that you basically spent 5 years preparing for. So now they have...
It's the test you never want to take again, right?
Absolutely, yes. It's a lot of...
Do they still have this oral test, or they got rid of it altogether?
No, they totally got rid of it. So now everything is sort of one of these computer-based tests.
Oh, and it wasn't like that before?
We took a physics computer-based test. We took a written computer-based test, and then at the end of residency, we took an oral board. So now they actually have something combined in your PGY4 year, and then something, I think 15 months after you've completed residency. So no one graduates radiology residency board certified anymore, which is what I did. I was board certified when I graduated. You graduate board eligible. And then there are 3 specialties, the interventional radiology, pediatric radiology, and neuroradiology. They actually also have separate certifications called CAQs.
So did you know through this entire process that you were going to focus on breast radiology, or did you have some inklings of considering other options while you were going through your training? So
I did plan on going into breast radiology. Again, some of that was from the breast surgeon that I had worked with in medical school, and then the mentor who was a breast radiologist. But certainly there are things that can seduce you over time. And so there was a brief period of time where I thought that interventional radiology might be a good way to go. Of course, at this point, I had learned that I like to work with my hands. I liked to work with patients. In the end, interventional radiology is intense. What they do is amazing. The hashtag is without a scalpel, meaning that, they're not making any cuts, but they're still able to treat almost every organ, or probably every organ in the body. That said, I just didn't think that the lifestyle was going to be as sustainable.
So do you think radiology is really meant for someone who is a morning person? Because it seems like you have to be up early in the morning.
I really don't think
or
that's
is that only during your residency training?
Well, I think in general, you can pick the lifestyle and the job that works for you. So if you want to be a nighthawk, you can be a nighthawk. That's someone who reads only at night. In my first private practice, we had a guy who lived in California, had a great life, and 1 week a month would come to this small town in North Carolina and read overnight for a week.
Oh, wow.
And he was pretty much being the stereotypical playing golf the rest of the time. So, if you want to choose that lifestyle, it's very specific. But otherwise, yeah, caffeine and mornings.
So you were done after your 5 years. You had completed your fellowship, correct?
No. So that was the residency.
Okay.
And I did a 1-year fellowship.
And where did you do your fellowship?
At George Washington in D.C. And it was just a breast imaging fellowship. Most radiology fellowships are 1 year, other than there are a couple of neuro fellowships around the country that are longer. And then if you do something more specific, like pediatric neuro or pediatric interventional, things like that, or neurointerventional radiology, so they're like doing the coils and embolizations, and you want them to have a lot of training, those can sometimes go up to 2 years.
So what are the options once you finish your fellowship as a breast radiologist? Do you work for the hospital? Do you work inpatient, outpatient?
Great question. So the practice structure for radiologists, as with a lot of specialties, has been sort of consolidation of practices. So I guess the first decision is academic.
That's the story, by the way, across all of medicine right now.
Right. Yeah, there's a lot of private equity buying out groups, things like that. So the first decision you have to make is academic versus private practice. And then there are plenty of hybrid situations. I'm a private practice radiologist who has academic appointments, but you sort of make that main decision. And then once you decide private practice, as a breast imaging radiologist, for me, I had to decide, I had to find a practice that I felt honored the training that I had and what I wanted to do, which meant that I wanted to do predominantly, if not entirely, breast imaging. You do see a lot of breast imagers who do a fellowship or any kind of fellowship, whether it's musculoskeletal, neuro, et cetera, and then they find themselves in these 50-50 situations where whatever fellowship they've gone on to do is only 50% of their everyday work. And for me, I love breast imaging. From a public health perspective, from a practice perspective, it's what I wanted to be doing. So I needed it to be. Do
you have to join a large group though? Or are you able to start your own practice? Or is that, those days are gone?
There's not a lot of throwing up a shingle, when it comes to radiology. I mean, just the equipment alone would cripple a person, right, to buy MRI magnet, to buy a CT scanner, things like that. So yeah, you're joining large groups. There are still some of these smaller groups that are surviving and thriving. They are going to be in smaller areas, kind of the 4 or 5 person in the 250 bed hospital in the hills of somewhere. There are a lot of these national groups now where, you'll be in a practice in New York, but it's owned by like a RadNet or a DR or Solus, things like that, and is part of a larger national company.
I'm assuming you get to interact with oncologists and plastic surgeons.
Yeah, so a lot. I mean, if I were in academics, that would be part of it. The breast cancer conference that I'd be going to weekly, which is what I did do in some of my prior practices. But even as private practice, I interact with breast surgeons daily. I interact with, like you said, oncologists, some plastic surgeons, rad onc, and then just a lot of, gynecologists and internal medicine, primary care providers. So,
if I may ask, are there any issues with liability? And the reason I'm asking that is because my aunt had breast cancer, and the MRI was negative, her mammogram was negative. But she decided to get both of her breasts removed, and then the pathology was taken on the second breast where the scans had been negative, and they discovered that she indeed had breast cancer. It seems like there's a lot of risk as a breast radiologist that you might not pick up certain things when you're looking at these scans. Is that ever something that you're concerned about?
So malpractice is an issue with, several specialties in medicine, and radiology is one of them. And of the lawsuits that are filed in radiology, I believe mammography is 50% and chest radiography is like another 25, or those numbers might be flipped. But
so it's very common. It's very common for these things to happen.
Right. So the bread and butter of those things. And here's the thing is that, mammography is meant to be annual, for a reason, right? We want to detect things when they're small, and that we know that breast cancers can be slow growing and detected at that pace. So when we're reading mammograms, I mean, we do things to optimize our, ability to read them. Of course the lights are off, it's quiet, we batch read them. We try to minimize other distractions, phone calls, seeing patients and things like that. And, of course, want to do them when we're fresh. And then you just have to make the call that's reasonable. You want to have your prior examinations, your comparison mammograms. 3D mammography has really improved the sensitivity and specificity. And then, for things that go on to lawsuits, was it a reasonable call? I mean, I do have colleagues, I know people who, do a lot of this like medical legal work. And really it's about showing that whatever call was made was reasonable. Was a normal, it wasn't basically malpractice, right?
It seems that if you're doing radiology, you have to be very visually oriented. Is that correct? Like you have to be someone who can recognize patterns.
Pattern recognition is very important. You have to be I mean, I think it's important to be cerebral. I am cerebral. You have to, be a problem solver. There has to be some spatial awareness, like particularly for mammography, right? I'm looking at a mammogram that looks at the breast one way. I'm looking at an MRI that looks at it another way. I go do an ultrasound that looks at it another way, and you have to put all those pieces together. So, yeah, it's a lot of problem solving. It is very, spatial and visual.
So we know that Google is doing a great job of figuring out images, right? You take an image with your phone, and they know it's a tree. Are you concerned at all as a radiologist about the future of radiology with the advancements of artificial intelligence, where images can be looked at, within less than a second? What's your take on that? Because I'm sure there are many students who are going to listen to this interview, and they're going to say, is there going to be a field of radiology?
Right. No, great question. And I actually have an Instagram post planned on this topic.
Well, I saw you tweeted about this.
Yeah,
so.
Yeah. And I get asked this question a lot. So here's the thing. As we know, for better or worse, computers are in our life, and they have changed them for better and for worse, right? So there's some things we're able to do quickly. There's some things that we've forgotten how to do. I mean, ask a kid how to write cursive and they don't remember how to anymore, right? So, do I think that a computer could ever entirely replace me? The short answer is no. Do I think that computers have the ability to do things better than humans? Sure. Some of them, right? I mean, Google has proven that it can find something in 2 seconds that would take me, 10 minutes to find in the phone book. But we've had computer-aided detection for a very long time, and studies have shown that it does not help radiologists, certainly not fellowship-trained breast imaging radiologists. They're trying to teach computers algorithms and to really recognize, again, teaching them pattern recognition. But I was at a lecture recently that showed one of these out of a children's book, like a highlights magazine that we used to read when we were little. And it had, you had to find what was wrong in the picture. And one of them was a duck sitting on a roof with a computer. Now, a 5-year-old could recognize that there's something wrong with that, right? Like a duck's not going to sit on the roof with a computer, but does the computer have the ability to really dissect that and know that that's abnormal? If they're just looking for things that are abnormal. So there's that. I don't think you can teach a computer everything. And the second thing is, I don't think that a computer is ever going to replace the compassion and the care that the doctors are able to provide. I tell women that they have breast cancer daily. I tell women that everything's going to be okay. I tell them, this is what I would do for my mother. This is what I would do for myself. A computer is never going to be able to say that. And for all that computers are able to do, I don't think the patients are ever going to fully trust them. So no, I don't think that they will replace me. 50 years, they might replace somebody, but for now, I think they're not going to replace.
Oh, they definitely will not replace you. So what are you most excited about in terms of where the field is going? Why should someone be excited to pursue breast radiology?
I mean, listen, it's all about the public health and just not only being able to take care of the patient that's right in front of you, but advances in the field that are helping women and some men around the world. There's constant innovation for imaging. I mean, 15 years ago, they weren't using MRI, and now it's, we fight about who should or shouldn't be getting it. We have 3D imaging that's really revolutionized the sensitivity and the specificity. We're always finding new ways to diagnose, to biopsy, to treat. So I like being part of a field that's always changing, that keeps me on my toes and just has the ability to impact people around the world.
Okay. Well, thank you so much, Dr. Malik. This was such a pleasure. And what I really enjoyed was how frank you were. You were completely honest. And I think it really comes through in this interview. So thank you so much for your time.
Thank you for having me.